Hello and welcome to Front and Centered, hosted by me, Patrice Charlotte, Communication Specialist for Equity and Community Health. The Mass General Brigham community care vans, initially focused on COVID testing and vaccines, are now providing prevention and management of chronic health issues in our local communities. On today's Front and Centered, you'll hear from Dr. Priya Sarin Gupta, Medical Director for Community-Based Clinical Programs at Mass General Brigham, and Cesar Guerra Castillo, Mobile Operations Manager. As always, we encourage comments and questions, and we'll have a dedicated Q&A at the end of the presentation, should time permit. We do ask that you save your questions until the end and submit them by using the Q&A button located at the bottom of your window. Should you have comments, please feel free to put those in the chat. And so with that, I will turn things over to Dr. Sarin Gupta to get us started.
Hi, I'm Priya Sarin Gupta. I'm a primary care physician at MGH Charlestown and the medical director for clinical community-based programs for Mass General Brigham. And I'm going to share some slides. So Cesar and I are going to talk a little bit about our community care van program. That's the community care vans that have been out in the field now for over 2 years. And I'm going to start out by talking a little bit about some of the work that we have been doing and how we sort of came to be. And Cesar is going to wrap up with sharing sort of the evolution of our work and where we're headed next. So to start with, our work began during the peak of the COVID pandemic. And at that time, many physicians across our system, other primary care physicians like myself, we were spending a lot of time volunteering in what the hospital had put up called respiratory illness clinics. And what we were noticing was that while we had increased some access to COVID care, testing, and later vaccination through these pop-up clinics, that there were still some patients that just weren't accessing the care. And a few of us got together and we thought, well, what if we could put these rigs essentially on wheels and take them out to the communities that were hardest hit by COVID to help really increase access and address sort of the other aspects of care that were so important at that time during the COVID pandemic. And namely, some of the themes that were emerging among some of our most vulnerable patients was things that related to social risk mitigation. So social determinants of health was becoming addressing those social determinants of health was seemingly becoming increasingly important to address as COVID surged in some of the communities in the greater Boston area. So initially, actually, through a small amount of funding that we received through the NIH, we were able to engage with many community key stakeholders in those communities like Chelsea, Everett, Revere that were hardest hit by COVID. And through early needs assessments, we were able to get a sense of what those communities really needed and also get a greater appreciation for how we could make care more accessible to those communities, especially in the way of COVID care. And then also some of our early work focused on looking at data like COVID rates, but also things like social vulnerability index. And with COVID, we were able to have some access through our community partners to wastewater data, where we were able to get a sense of where COVID was going to surge next, 10 days before we were going to see it in the PCR test results. And through, involving and collaborating with key stakeholders and using this data-driven approach, what we did in those early months was launch a van, the MGH COVID Care Van, where we were able to go out in the communities and provide PCR testing and also social determinants of health screening. And additionally, when vaccinations became available, we were able to provide vaccinations. And throughout all of this process, this key stakeholder engagement has been a big part of our work, and it has led to what we are focusing on now, which we'll get into in a little bit. So over the course of the last 2 years of these vans being out in the communities, we have been able to provide a number of services. So we initially started out by providing COVID testing, and we were able to provide about 10,000 COVID PCR tests, and we continue to have on our vans the option around test and treat and rapid antigen test kits. In May of 2021, we transitioned into providing COVID vaccines. And then when the pediatric vaccine got approved, we really shifted our efforts to helping to vaccinate the pediatric population. And again, key stakeholder engagement continued to be a big part of our work. When we were focusing on the children, we were often co-locating at school during dismissal time or during the school day. And then with some of our other patients, because our goal throughout has been to really reach historically minoritized patients. We've been working with community organizations to sort of be present or co-locate when they're having other events. So, we're often in Chelsea when there's a food distribution line, or in another area when there is a community organization doing a diaper distribution and things like that. This past fall, we added flu vaccines to our menu of services. And these are just numbers for our one van, the MGH craft van, in the number of services that we've been able to deliver. And then last summer, we added blood pressure screening visits, and we're now transitioning into more intensive clinical visits around blood pressure and diabetes. And we've also, as of January, by collaborating with Bridge Clinic and addiction medicine trained providers, we're able to provide substance use disorder care on the vans. And for all of this work, there's a clinical component, but also a risk reduction component to our work. And throughout, we've been doing social determinants of health screenings, like the same validated screener that individuals get if they come to any of our brick and mortar clinics. And the idea is to, meet patients where they're at in the communities, but not leave them there. So for anybody that we screen, and for anyone that screens positive, they are then connected to a community health worker and then connected to resources. And we're really trying to make sure that we're able to address, anything that they screen positive for. So some of the lessons learned about mobile health from some of our early work was that mobile health can help decrease barriers to healthcare access, and that we can use mobile health to help address social determinants of health, because we were able to take away some of the early barriers that existed to individuals who were having trouble accessing, COVID testing and vaccinations. We run a primarily walk-in model for our clinics. We're out in the communities at hours like 3 p.m. to 7 p.m., often when brick and mortar clinics are closed. And we were able to really be available for those individuals that are essential workers or working multiple jobs and able to come in at sort of off hours. And to that end, we also found that mobile health has the potential to support equity. And as a result of all this, and as the COVID pandemic has sort of stabilized, we began to think about how might we be able to leverage this mobile program to better reach, to better provide high quality healthcare to vulnerable populations, and to really reimagine our hospital's front door, essentially. And to that end, we now have 3 vans that are each DPH licensed and connected to an MGB entity. So we have the MGH connected van, a van that's connected clinically with Salem Hospital, and then a van that's connected to Brigham. And we've really expanded our menu of services beyond COVID to include hypertension, chronic disease treatment, and SUD care. And really, like our work since the beginning, data and community input has really driven how we've chosen these priorities. So historically, when you look at the data and you look at those health conditions that disproportionately increase morbidity and mortality in historically minoritized populations, cardiometabolic and SUD emerge in the greater Boston area. And so that's why we've chosen these as our sort of areas of focus. And what we found from our works so far is that by putting these clinics on wheels and taking them out to the community, we were indeed able to service majority of individuals who are on public insurance, who are ethnic minorities, And so we're hoping to be able to partner with some new community organizations, and we have some ongoing partnerships to be able to take these vans now to those communities that need these expanded services most. And as our program has grown, we on each of our vans, we have a core a staff that consists of a physician lead, a full-time nurse practitioner on each van. We have a medical assistant, a community health worker, and an operations manager who are boots on the ground, helping us take care of these patients and communities. And we see all comers on the vans, and we really try to be a bridge for them to care and connect them back to their medical home if they have one, or help guide them to be connected to a permanent medical home. And as we've progressed, we've also become as a teaching site for community health, because I think a big part of the sustainability of this work is encouraging and training our trainees to learn about community health and see all the different ways that community health can be employed in our communities, especially as connected to big academic centers. And to that end, starting July, we will have we are working with the internal medicine residency program to create a universal community health rotation experience for all Mass General Hospital internal medicine PGY1 residents, which is about 86 interns every year. And they will rotate through the community care vans and also have some opportunities for some longitudinal experiences to really have the opportunity to immerse themselves in community health in a meaningful way. And then just, wanted to highlight that, as we're going into these new spaces around cardiometabolic conditions and substance use disorder care, we have found good success with the blood pressure screenings that we implemented starting last May, in who we've been able to serve and reach out to, astounding numbers of Black or African-American patients that have come to our vans for screenings, 19% from the latest numbers. And then also a great portion of patients who cite Hispanic as ethnicity, a greater portion of males to females. And all of this data is really meaningful in guiding our work, because it is exactly the patient populations that we're trying to reach with this work. And now I'll actually turn it over to Cesar, our operations manager on the Mass General Hospital Community Care Van, who will talk about some of the expanded menu of services and what we'll be providing.
Thank you, Priya. So my name is Cesar Guerra Castillo. I'm the mobile operations manager for the MGH Community Care Van. And as mentioned before, our work has evolved from what was supposed to be just a 20-week pilot that offered COVID testing and treatment to now a full-scale program that offers a range of primary care services. By working with our community partners and key stakeholders, we have been able to implement services that cater to the ongoing needs of the communities we work in. The evaluation part of our work primarily has been proven to be a successful model for our future decision making, and is what really makes us unique in our approach to bring on new services. And as you can see to the graph, we started SDOH assessment and referrals pretty much since the start of our services, but we've been able to add on services such as hypertension screening earlier this summer, and then we have been able to shift to substance use disorder services at the start of last month and early December as well. And in addition to those services, we've been implementing flu vaccinations as of November of last year, and we are hoping to add on kind of diabetes medication management at the end of this month, actually. So Priya, next slide. And while COVID has been and will continue to be our primary focus for us, we're excited about transitioning into more long-term health interventions and being known for more than just a vaccine van. We have expanded our menu of services to address chronic health issues such as hypertension, diabetes, and substance use disorders through both clinical and risk reduction interventions. Across all three services, we are using targeted approaches like behavioral health education, point of care testing, pharmacotherapy, and social needs assessment/referrals to create comprehensive health plans for our patients with the goal of engaging them into long-term sustainable care. And as you can see in the graph below, we have added kind of two sides to our care, right? Clinical services and risk reduction services, where a lot of the focus is around educating our patients, kind of creating a comprehensive health plan for them, involving things like physical activity assessments, lipid screenings and A1C testing, point of care, screening for sleep deprivation, smoking cessation, and depression, as well as food insecurities. And then as well as creating kind of a follow-up plan, either with us or with their primary care home, wherever they're docked in. And in terms of risk reduction services, we provide BP cuffs to patients that kind of have a high blood pressure in our initial follow-up. And then on site, we teach them how to use the blood pressure, how often they need to take it. And then we kind of engage them to kind of come to our van in a consistent manner so they can have their blood pressure checked, whether that's kind of on a weekly basis or a bi-weekly basis. I think the mission for us is to engage patients in the care long-term. And next slide, Priya. And for substance use disorders, again, we kind of break down our services according to clinical and risk reduction services. And we have the privilege of working with the MGH Bridge Clinic for this part, where a lot of the care is involved around peer support and recovery coaches, as well as pharmacotherapy. There are about 2 providers on each session, on each SUD session, which right now we're offering twice a week, primarily, 1 every Wednesday, and then we offer about 2 sessions a month every Saturday for that month. And we have 2 bridge clinic providers that come in. They kind of provide support and outreach for anyone needing specific SUD care. They offer things such as assessment of mental health comorbidities, initiation of pharmacotherapy for either depression, anxiety, or other social circumstances that affect their health. And then for risk reduction services, they offer things such as SDOH screenings. And then from there, we kind of go into our process, and then we follow with those patients, connecting them to long-term resources and just basic kind of social needs that affect their health care long-term.
Cesar. And this is just a picture, or a few pictures of our MGH team and some of the leadership who we work with, as well as a picture of our van at one of our community organizations. And just wanted to give a special thank you to our funders, the Kraft Foundation, the NIH, CVS Foundation, and the United Against Racism funding from Mass General Brigham.
Thank you.
All right. Awesome. Thank you so much, Priya and Cesar. That was amazing. And it was an incredible overview of the very impactful work that you all are doing. So I'd like to now open it up for Q&A. So as a reminder to submit questions, please use the Q&A button located at the bottom of your screen. So we have received a question already in our Q&A. So Priya, Cesar, one of our audience members asked, what qualifies a patient for a positive SDOH screening?
Sure. So our SDOH screener, it's like a standardized screener that we use in the entire hospital system. And if someone cites positive for any of the questions we ask, so we ask about housing stability or instability, we ask about food insecurity, we ask about transportation, job security. So if someone cites positive to any of the questions, then they are considered a positive SDOH screener. And then we put in a referral to our community health worker team. And we have a full-time community health worker connected with our van, who then picks up the intake actually immediately, because she is at the van when the patient is there, but then also has a workflow where she follows up with that person and then connects them to the appropriate services. And, it's actually interesting because people may have short-term needs or sort of longer-term needs. And that's, been something that, we've gotten to experience and learn through this work. And it's actually evolved as the work has evolved. So, in the early days when we were doing more COVID work, there were certain needs that were very consistently emerging. If you had a patient that lived in a multi-generational family and then tested positive for COVID, they might have like a temporary housing need. But I think the one thing that we realized though is that, there certainly are so many social risks. And until we work hard around that social risk mitigation piece, we really can't make the impact that we want to in our healthcare system. And so, fast forward to last week, we were co-located in near actually my clinic in Charlestown, and a patient, walked quite a ways from his housing development, a 64-year-old man who came to the van actually not looking for clinical services, but asking for food. He had a daughter that had recently overdosed and was admitted to the hospital. And now the 64-year-old man had like 4 children in his house that he was trying to feed. And he literally just came to the van looking for food. And we were able to, set him up with like a box of food, and then also set him up with like a gift card to get some groceries. And so it really speaks to how important thinking about these social determinants of health are. And, we're so grateful to have this opportunity to be a part of making some impact in helping to address some of them.
And I just want to add on to the point, a lot of the kind of social determinants of health aspect, it can be intimidating for a lot of patients. They may not often state that they need help or they want help. That comes with a lot of stigma. And I think with us, for our team and our staff, we try to prioritize and kind of build that trust with them to kind of ensure that any support that they may ask for, whether it's short-term or long-term, we can help with it. And it just kind of gives a sense of trust and building that relationship with that specific community, because from what we understand, every community is different. Every community has different needs, has different circumstances, and every population is going to be different. One population may have short-term needs, while another population has, more chronic long-term needs. And for our staff, we try to be aware of that in every community that we go to. We can't expect the same out of every neighborhood that we step in, and we can't bring the same approaches to every community or every part of the city that we work in. So we really try to pride ourselves in being aware of that and conscious of that.
That's great. Thank you so much for answering that question. So on the topic of what you've learned and all of the things that you have discovered in this work, and also seeing how positively it's impacted the community, some folks in the Q&A are asking, what is the future of this work? Is there an idea? Is there a plan to extend this beyond Boston? What does the future hold for the caravans?
There's lots of wonderful mobile health programs actually across the country that are all doing very, very important work. The focus of our work is right now is really to serve our greater Boston community. I think what makes our work a little bit unique compared to many of the mobile health programs that I'm aware of is that we're able to provide clinical care in addition to health education and risk reduction. And we're sort of a unique use case for that. I think we have a lot of work cut out for us right now in our greater Boston community. And, we're very committed to providing work that, for doing this work in these communities with strong partnerships and being very attuned to a cultural humility and bringing care in a way that's most receptive. And so that's sort of our focus now. And then we'll see where the future takes us.
Great. So again, kind of just thinking about the community, thinking about the future and what you've learned, what are you hearing from the community? Have you received any positive feedback? Have you received any challenging feedback that's kind of helping you to evolve and shape this and develop it further? What are the positive and negative things that you're hearing out there?
Yeah, I can speak on this. Well, I'm pretty much out in the field at least 5 days of a week, maybe 6, depending on the week or the season. But with our work, we try to bring as much consistency, as much passion, as much understanding with the work that we do with our patients. And for the most part, they've been very receptive about our work. They appreciate our consistency. They appreciate the fact that we come in and that we try to understand, we try to be compassionate, we listen to them. We find that a lot of patients love being listened to. They have stories to tell, and they have challenges that they face every day. And sometimes they just want someone to listen to them. Sometimes they just want to be heard. And from our experiences, we have received a lot of stories from patients where they go to primary care homes and they feel like they're rushed. They feel like they're just not being listened to. They're not being understood. They're being misdiagnosed and all these different things. And for us, quality is so big and so huge for us, because we are not only representing, MGH or the hospital as a whole, but we're representing kind of the quality and cultural and linguistic competent care that we kind of pride ourselves and set ourselves to do. So those are some of the good things that we've heard. But some of the challenges that personally I have encountered with this work is that there's so much work that needs to be done. There's so many areas that we need to tap into, AKA mental health, AKA maternal health, just nutrition. Like there's so many kind of different needs that patients needs. And like, while we would love to kind of aim for them and kind of bring all these solutions to all these problems, I think with us is that we're trying to kind of take one step at a time and kind of meet patients where they're at, right? Like the whole point is that patients don't have access. There is a discrepancy in them getting to a hospital or making time to kind of prioritize their health. But for us, we're trying to come in and be that bridge that connects them to long-term healthcare. We want them to kind of plan for their future. We want them to kind of take better care of their health, because at the end of the day, health is wealth. And if you're not healthy, you're not going to be able to sustain yourself or your family or kind of build the future that you set out to be. So I think with us, it's just helping patients take it one step at a time, taking their hand, guiding them, and just being for them consistency, letting them know that we're going to be here at this time, at this day. And that's big for us. And it's proven to be successful.
That's great.
And I'll just add, I think one of the things that we've really learned from doing this work, both when you think about the challenges and the positives, is that there's so much to be said about the community engagement piece and the key stakeholder engagement piece. I remember early on when we first launched the van, we went into one community it was like the middle of the COVID pandemic. And we went into one community to provide PCR testing. And we had like 100-something people line up for PCR tests. And 2 days later, we went to another community and there were 7 people that showed up. And, the community prevalence of COVID was the same. And the biggest difference between the two communities was there was one community where we as a system had this amazing rapport as being providers that were really invested in that community. And for that second community, we didn't have that yet. And we spent like the next 8 months really building inroads with the community organizations in that second community. And when the pediatric vaccination was approved, several months later in November 2021, we went back to that second community to provide vaccine. We had been going to that community, but we were back there providing pediatric vaccinations. And at some point, we were behind vaccinating something like 40% of the 5 to 11-year-olds in that second community. And it really was just such a great example of how if you engage the community members and the community organizations that community already trusts, you can have such a huge impact.
Thank you both. So on the topic of the unique challenges of our community, some folks in the audience are curious to know what the plans are around ramping up SUDS treatment.
Sure. So a big goal of our work is to not fragment care, but really to add to the care that we're providing our patients. And it is for that reason that we have partnered and really integrated our SUDS services on mobile with the MGH Bridge Clinic. And the idea being that we are sort of a bridge to care out in the community, but with the eventual goal of connecting our patients who have substance use disorders, concerns and care needs back to the brick and mortar MGH Bridge Clinic. So we're working together to make sure that we can make available to these individuals that we see through the mobile platform the same services that they would get, if they walked into 55 Fruit Street for that care.
Yeah, and also just to add on, SUD care is such a taboo subject. There's so much stigma and just so much involved with just that patient population. And the biggest feedback that I've seen while we're out in the field is that they love consistency. They love the fact that we show up at a specific time, a specific day, every day, and that we kind of are there for them when, where they can just come in and go as they please. We're not trying to force kind of this relationship with them. We're trying to build that trust. We're trying to build that consistency because it's so important, with this population specifically. It's been kind of a population over time that's been so forgotten about, that's been kind of stigmatized to the teeth. And for us, we just want to pride ourselves in being there for them when they come, and like to come as they are, and that's where we go and we work with them from there. Like I mentioned, baby steps, engaging them in this short-term help for long-term future or sustainable care.
It's fantastic. Well, thank you, Priya. Thank you, Cesar, for answering those questions and for just giving us insight and giving us tips on how this can inform our work in some way, shape, or form. So again, thank you, thank you. And so for those in the audience, that does conclude this month's Front and Centered. Thank you again to our presenters and all of you for attending. We do hope to see you at our next Front and Centered, which is happening on March 30th at noon, where we'll be featuring the work of the Center for Gun Violence Prevention. So thank you, everybody. Take care. Have a good one. Bye-bye.
Thank you so much.
Bye.